I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University in Canada, and I'm thrilled to have with me Dr. Ajay Kirtane, Professor of Medicine at Columbia University Irving Medical Center, who is here to discuss the RADIANCE-HTN TRIO trial that he led and will present at the late-breaking clinical trial session at ACC. Welcome, Dr. Kirtane.
Welcome so much. Thanks for having me.
So I have to start with a very important question. You have to tell us how an interventional cardiologist develops an interest for renal denervation therapy and how this denervation actually works.
It's a great question. And first and foremost, I want to recognize my mentor and co-principal investigator along with me, Professor Michelle Azizi, and also Laura Mori, who was instrumental in the design of the study. You know, the reality with interventional cardiology, and I think you may have heard me say this before, is we like interventions that work. And we know that hypertension is such a great public health issue that interest in ways to address the control of hypertension is something that should interest any physician that's out there, whatever field you're in. And so as renal denervation started to come to fruition with a lot of excitement several years ago, interventional cardiologists, many of us felt that this might be an area where we could help and we could address patients that had difficult to control blood pressure. There was this upswing of enthusiasm, then a downswing. And I think with everything in time, there's always a balancing. And I think we're at that point right now. And that's why we're very excited about this study.
That's understandable. So what was the rationale for this trial and what hypothesis did you test?
I think that what was unclear after Simplicity Hypertension 3 came out was whether there was actually a treatment effect of renal denervation compared to a sham control in terms of lowering blood pressure. And one of the things that a lot of people took a long, hard look at those data and realized was that there might have been a signal that we saw in prior studies, but the way the trials were designed, this signal was lost in a lot of noise with medications going up and down. And we also needed to optimize devices, optimize the technique in order to potentially see if this could work. And so one of the ideas of this study, as well as RADIANCE-HTN Solo, which we previously published, was to try to stabilize the baseline medication regimen across both study groups and then conduct a sham-controlled study to determine if denervation could lower blood pressure relative to a sham control. The specific hypothesis in RADIANCE-HTN TRIO was, could we demonstrate that renal denervation compared to a sham control could lower blood pressure in patients who were resistant to hypertensive medications at baseline? One of the unique attributes of this study was that we took patients and put them all on single combination therapy. And Harriet, I know that's an interest of yours, but essentially to stabilize that baseline between both groups to then be able to specifically test the hypothesis in a somewhat purer way than if we had patients who were on multiple medications that could be varying up and down through the study.
Right, and perhaps that approach might have facilitated treatment adherence because medication non-adherence is a big problem in treatment of hypertension. So a good strategy to perhaps decrease polypharmacy, increase adherence, and then maintain balance in co-interventions between the groups. Tell us, Ajay, what were your eligibility criteria?
In general, patients had to have elevated blood pressure at baseline screening. So in our presentation, there's screening, then there's the baseline after being on the triple therapy, and then there's follow-up. But at screening, they had to have quite elevated blood pressures despite being on 3 or more antihypertensive agents. In general, they were on 4 agents and had entry criteria office blood pressure of 160. Once that was confirmed to be true and standard exclusions were eliminated, they were put on that single pill and then reassessed once again to make sure that they still had elevated blood pressures, both by office as well as ambulatory blood pressure monitoring. And then at that point, if they were still elevated, they were then randomized in the study. One point I do want to make is that one of the take homes from this study for me as an investigator and as an interventionalist, I learned a lot, is that there are a large number of patients who you put on single dose combination therapy or 3 doses, but single pill combination therapy, whose blood pressure is better controlled. And so even outside of the study, I started incorporating that into my practice because, as one can see from our publication, there's a large number of patients enrolled and a small number of patients who subsequently went on to randomization because many of them did not meet elevated blood pressure criteria after being started on the single pill.
So there was a run-in phase, was there?
There was 4 weeks.
Okay. And so then patients who had persistently elevated blood pressures were then randomized to the intervention or the sham control. So how many patients did you randomize?
There were a total of 126 who got randomized. The one other point to mention is that we did ascertain adherence by urine chromatography. And remarkably, in this study, the rate of adherence was 75 to 80% on the single therapy. I don't think that would be as high, it would be that high in routine clinical practice. So it speaks to the fact that they were in a protocol as well, but it also speaks to the effectiveness of a single combination pill.
Absolutely. Tell us about the actual intervention for physicians who might not know what it entails.
Essentially, arterial access is obtained. At present, the system is femorally based, but it will likely be radial soon. You basically cannulate the main renal artery, advance a wire across it, advance a balloon catheter, and then gently inflate that balloon catheter so that you can oppose the device to the vessel wall. With ultrasonic heating, there's actually thermal ablation of the nerves in a circumferential pattern around the artery. So this differentiates it from other technologies. But there's a cooling balloon that prevents luminal injury. And that's why, to date, the longer term data have not shown deleterious effects like stenosis in the renals. There's typically 2 to 3 ablations performed on each side. And the ablations themselves are only 7-second sonications. They're really quick. And at least in this study, the randomization was to angiography in both arms, angiography plus denervation in one arm, and just angiography alone in the sham arm.
Right. There might have been interesting research ethics boards considerations, I might imagine, for a sham-controlled trial, particularly one involving radiation. How did you navigate that?
It was something that had to be done site by site. It's a challenge with all types of research like this, but we did feel, especially in light of Simplicity Hypertension 3, that there was a need for sham-controlled studies to really determine if there was a placebo or an effect above that beyond placebo to then be able to move the field forward. And fortunately, that was agreed to by most ethics committees. There's also a crossover potential for patients late. We have not done that yet, but that's something that can be done for patients who remain with elevated blood pressures. They would potentially be eligible for crossover well beyond the ascertainment of the primary endpoint.
That's interesting. So tell us your primary findings.
Well, essentially what we found is that there was a drop in blood pressure in the denervation arm that exceeded that in the sham arm by a median of 4.5 millimeters of mercury in daytime ambulatory systolic blood pressure. Now, for clinicians, though, we practice outside of sham-controlled trials. So the drop from baseline was actually 8 millimeters of mercury overall, which is, I think, pretty significant, especially considering where these patients started off with blood pressures greater than 150 despite being on the combination therapy. The reason the endpoint was at 2 months is because in order to essentially maintain no changes in medications over time, you can't really allow this study to protract for too long. We actually needed to have rescue criteria involved in case patients got too elevated. For instance, that happened in the sham arm, that didn't happen in the denervation arm. But yet at 2 months, there was a greater drop in blood pressure with denervation compared to sham. We also showed data in the Lancet publication and the presentation looking at office blood pressure, home blood pressure, nighttime blood pressure, and even the ABPM curves and the individual patient data so that the granular data can be seen by all.
Wonderful. Those are very promising results. Tell us about the safety endpoints, both intraprocedural and any long-term follow-up data.
Well, follow-up in this study will be going out to 5 years. That will be also combined with the other study, RADIANCE-HTN Solo. These studies are not powered for safety, so it's important to recognize that every event needs to be scrutinized. At least within this study, there were no appreciable differences between arms. There were 3 safety events that were seen. There was one unexplained death that was adjudicated not to be due to the procedure itself that occurred at 21 days. There was a femoral access site pseudoaneurysm that required thrombin injection, And there was one doubling of creatinine that occurred after initiation of spironolactone that then resolved immediately when that drug was stopped. So those were the events that we've seen, but we clearly need longer term follow-up, not just for safety, but also for efficacy to be sure that these results are durable over time.
Right, and then perhaps follow-on studies that are adequately powered to assess for efficacy on clinical endpoints. What are the costs associated with renal denervation? And if effective, do you think that this is something that can tackle the burden of hypertension in a practical, implementable way?
Well, I think I'll answer the second part first. For me, the right population of patients who could be offered this to would be those who have tried and for whatever reason, they don't want to, they have side effects, or they failed medical therapy, they still have uncontrolled blood pressure. So the way this was essentially touted several years ago is this could cure hypertension and you wouldn't have to take medicines. I don't think any of us believes that's the case now. We view this as part of an armamentarium to treat elevated blood pressure. The advantage of it is that it's a procedure that's a one and done procedure, and whatever that cost ends up being, and frankly, I don't actually know what the cost is because here in the US, it's not approved. I would hope that it would be something where it would be relatively short. This could be an outpatient-based procedure. There's no implantable device, and that it would essentially offset the lifetime cost of additional medications that people would have to take and side effects and doctor's visits, et cetera. But the way I view it is it's just part of the armamentarium of tools that we would want to use to address the burden of uncontrolled hypertension which is remarkable. If you look at the JAMA paper in the last year about rates of control and how many people are controlled despite being on medicines, it's really, really sobering, and we've not made much progress.
Absolutely. I'm going to shift gears a little bit and talk to you about enrollment and diverse enrollment in clinical trials. Hypertension in particular affects disproportionately Black Americans who remain underrepresented in clinical trials. This was a small trial. You got about 20% Black patients enrolled. What strategies did you embark on to ensure engagement, broad engagement, and diverse enrollment?
Well, first, I think we have to do better. It wasn't just 20% who were identified as Black. It was also 20% women too, and that's clearly not good enough. So I think that what actually has to happen is there has to be directed outreach that is relevant for individual communities. One of the interesting things that we've looked at within this entire RADIANCE-HTN program that was sponsored and funded by the company Recor is there was a lot of outreach on social media. And in fact, social media enabled many more patients to potentially be interested in the study and asked to be involved than any other study that I've ever seen. But one could argue that the demographics that are targeted through social media and the way in which they might be targeted might vary based upon the individual demographic. And so clearly we have to do better. The barbershop studies showed us that very, very nicely in contradistinction to this one in particular. So my sense is going forward with the next study and the next studies, this will be addressed in a better way that can address the fact that we really, honestly, if you think about where hypertension affects people in terms of events, we should be going out of our way to target, for instance, the Black community for potential studies that would maybe help them, not just to do experiments clearly, but studies that would help them and help other communities that are underserved and otherwise really affected by hypertension and their side effects.
Yeah, perhaps meeting patients in the location of their choice, meeting them where they are, both physically and in their disease journey, and also designing follow-up that might be more conducive to those who have multiple roles in their lives and may not be able to meet us in our clinic space for follow-up. What are your take-home messages for the clinician?
I think for the clinician, number one would be remember that hypertension is a major public health issue and it remains uncontrolled. There is hope for patients that even have difficulty taking medications, number one, through combination therapy, but number two, if devices like this are approved, for other ways to help treat these patients. Bottom line, though, is we need to do everything we can to address hypertension. We were hopefully able to contribute in a small way towards that. We do hope that ultimately with the pivotal study that's ongoing right now, and then we'll hopefully get completion, devices like this will be approved. And then it's on us to be able to use them responsibly to be able to take care of patients better and ultimately help their outcomes.
So who would you not offer this therapy to based on your trial?
Well, certainly I wouldn't offer it to somebody whose blood pressure is well controlled and okay taking medications. There are anatomic criteria that potentially would exclude them. Interestingly, subsequent to the conduct of this trial, there's been additional catheter sizes available, so we would probably be excluding less people now than we did during the trial itself. And I think people need a reasonable shot at medical therapy first before going forward and then getting a therapy like this. On the other hand, what's nice about this is that it's always on. And if it works, then you're going to have an effect that's on. So that may be advantageous. But remember, not everybody responded. So we need better data to try to figure out who the responders might be. And also, can we predict during the procedure when we've done a complete ablation or not?
Fantastic. Well, congratulations on a well-run trial. I'm so excited that you will present it tomorrow, and I look forward to tuning in and catching it live. Thank you so much for joining us, Ajay. It was my pleasure to see you again.
Well, thanks for having me.